Hospital at Washington University, fellowship training in hematology oncology at Duke University, and a fellowship in drug development at GlaxoSmithKline in the North Carolina Research Triangle Park. He has also earned a master's in health science in clinical trials at Duke University. He completed his undergraduate degree, a bachelor's degree in biology from Rice University. As you can tell, we definitely have an expert with us tonight. Please join me in welcoming Dr. Albert Craig Lockhart, our guest speaker tonight on colorectal cancer. Dr. Lockhart, before I turn it over to you, I want to let everyone know that we are going to have some time for questions and answers at the end of tonight's presentation. So you can feel free to put your questions in the chat box. I will field those throughout the evening, and at the end of Dr. Lockhart's talk, we will have some time to ask him those questions. So throughout his talk, feel free to begin putting your questions there. Dr. Lockhart, I turn it over to you.
Thank you so much for the kind invitation. Thank you for the blessing before we started. And I have 25 slides, so we should have a lot of time for questions at the end. I'm actually open, if somebody has a burning question during it, I'm happy to try to address that as well. I don't want somebody to forget about their question as we go along here. I've been taking care of patients with gastrointestinal cancers for over 20 years now. And so this is something that is near and dear to me and something that I've seen improvements over the last 20 years, things that, we do now that we didn't do 20 years ago. And I've seen things change and get better overall. And so I hope to highlight some of those things, and then also to, just highlight the importance of colorectal cancer screening, especially this month where it's Colorectal Cancer Awareness Month. So we're going to start off with, this is an outline of the talk, and I say we have about 25 slides to get through. We'll talk about facts and figures first. How often are we seeing these cancers? And then we'll talk about the anatomy of the colon, and then also anatomy of tumors and polyps and those kinds of things. Some of the common symptoms that we see with colorectal cancers, some of the screening options that we have. There are one or two that I believe in more than the others, but I'll highlight that. The current screening recommendations, which pretty much people between 45 and 50 need to start, looking into colon cancer screening. Talk about some of the risk factors for colon cancers, some of the things that we can do to reduce the risk. I'll have one slide on treatment because treatment gets very complicated very, very quickly. And we could spend hours talking about that, which we won't do that. And then just a brief take-home message. So to start off with, about 151,000 patients will be diagnosed with colorectal cancer in the United States. The 5-year relative survival for those people, if you're diagnosed with colorectal cancer, about 2/3 of those people will live 5 years. About 1/3 of those people will die, just depending on what stage of cancer that you're diagnosed with. The rates of colorectal cancer are actually lower in South Carolina than nationally, but the death rates for colorectal cancer are actually higher in South Carolina than they are for the rest of the country. There are also death rates for colorectal cancer actually higher for Blacks and for whites in both men and women. So again, something that's, this is a very, very common cancer. It's the 3rd most diagnosed cancer in the United States. And it is also the 3rd, well, behind skin cancer, if you don't think about skin cancer, then also the 3rd cancer that's most responsible for cancer deaths. So again, a very common cancer, and one that, again, will run across frequently. The important thing here is that about over 1/3, almost 40% of these cancers are diagnosed at a localized stage. That means the cancer is only in the organ itself. It's only in the colon. It hasn't spread anywhere, not even to the lymph nodes. And as you can see on the panel on the right, is that with localized cancers, if it's diagnosed at a localized stage, and I'll harp on this a lot, 90% of those people are curable. So, you know, it's about, you know, almost 40% are diagnosed at this stage, and 90% of those patients are curable. So this is a very curable cancer if it's caught at an early stage. So the lifetime risk incidence of colon cancer is about 5%. So 1 in 23 men and 1 in 25 women. Almost 90% of these cases occur after age 50, but importantly, 12% will be younger than age 50. And actually what we're seeing trend-wise is that more and more patients, this 12% is growing. It was 10% a few years ago. Now it's 12%. And this is a trend that's growing, that we're seeing younger and younger patients diagnosed with colon cancers, you know, below age 50. So the recommendations now for screening have gone down to 45. Where they used to start at 50, but I'll talk about that in some subsequent slides. The average age of diagnosis is 66. So as I said, the majority of cases occur after age 50, and about 1/3 of patients with colorectal cancer die from the cancer I mentioned that a couple slides ago. But colorectal cancer is largely preventable. It's not 100% so, but it is largely preventable. And again, I'll talk about some of that as we go forward. What can we do to prevent colon cancer from even being diagnosed? So we're going to talk a little bit about anatomy first. The colon and the rectum together, colorectum, make up the large intestine. The function of the large intestine is to absorb water and electrolytes from what we eat and what we drink, and then also to eliminate waste. In general, the colon is divided into 4 sections. We have I don't know if you all can see the pointer, but it is the ascending colon, which starts just at the small intestine and your appendix is here and goes up. And then we have the transverse colon, which goes across from right to left. Then you have the descending colon, which goes down along the sort of left side and before forming this S-shaped part, which is the sigmoid colon, which goes into the rectum. So we're talking about 4 parts here. So quite often, when somebody's diagnosed with colon cancer, they'll say, oh, they had a colon cancer of the ascending colon, a colon cancer of the transverse colon, or the descending colon, or sigmoid colon. So some of this is to explain different parts of the colon. Now, it's a little bit more anatomy here. So colon cancers in general arise from polyps. And this is why I'm going to say that colorectal cancer is preventable. In that over about 10 to 15 years, a polyp can go from just a simple polyp all the way to an actual cancer. This is about a 10 to 15 year process. We don't exactly know how long, but it's somewhere in that, somewhere in that range. And we have pictures here of what a small polyp would look like under A, then under B, sort of more of a polyp with a stalk on it. And then also this is more of an actual colon cancer lesion here. But as I said, this is a 10 to 15 year process. If we can eliminate the polyp at this stage, at stage A, or even eliminate it at stage B, you can prevent these things from progressing towards cancer. So in a lot of cases, colon cancer can be preventable if you undergo routine screening and address some of these things before they develop into colon cancers. So 2/3 of polyps are adenomas. There's some other polyp types that are also benign. Adenomas are benign. In fact, these polyps here in these pictures that I'm showing here would still be benign if you took them off. However, if you leave them there and they grow big enough and they start developing mutations over time, they will become malignant if you leave them long enough. And if the polyps get big enough and you have enough of them, it's more than likely that they will develop into cancer. If they do colonoscopies on 50-year-olds, all 50-year-olds, 25% of 50-year-olds will have a polyp somewhere. 50% of 70-year-olds will have a polyp somewhere. So as we get older, it's more likely that you're going to develop polyps. And if you leave the polyps alone and just sit them in there and they start to grow and continue to grow and there are more of them, it does increase the likelihood of one of these things turning into a colon cancer. So this is where I was talking about preventable. This is what I meant. Now to talk a little bit more about colon cancer staging, in that in general, once it's become a cancer, then then the staging, gets even more important. So stage 0, those tend to be really small tumors. They have not spread to any of the lymph nodes. Stage 1, similar, a little bit larger. It's invading a little bit more into the wall of the colon, but still hasn't spread to the lymph nodes. Again, stage 2, stage 1. Stage 2, still a little bit bigger, not into the lymph nodes. And so any of these 3 stages, if we get the colon cancer out at stage 0, stage 1, or stage 2, you're talking about 90% cure rate. Over here on the right side, you're saying that 90% of those patients are curable if you can get the cancer out at stage 0, stage 1, or stage 2. Now we get into stage 3, and now we fall into our regional category. And stage 3, the tumors are a little bit bigger, but they've also spread to the lymph nodes. Once we get into that category, the cure rate is somewhere in this right around 70%. Those are the patients that we have to give chemotherapy to reduce the likelihood of the cancer coming back. But the cure rate has gone down once the cancer has gotten to a higher stage. Stage 4 cancers, those tend to be larger tumors. They've definitely spread to the lymph nodes and quite often have spread to other organs as well. And as you can see here on the right panel, about 15% of those patients can be cured, and we consider 5 years essentially cured, not 100%, but 5 years are essentially cured. And so about 15% of those patients can be cured once the cancer has already spread. So again, it's important from a polyp standpoint to get the polyps out, and then also once the cancer is diagnosed, to go ahead and treat it, at an earlier stage rather than a later stage. Okay. I'm going to talk for a couple minutes here about the symptoms of colon cancer. Since it's in the colon, all these symptoms are going to be bathroom kind of things. So if you're not comfortable talking to your doctor about bathrooms kind of things, you need to change that. If you don't feel comfortable talking to your doctor, talk to your families, talk to somebody, because these are all going to be bathroom kind of symptoms. And if you're not comfortable about that, we need to get more comfortable with that. So what are some of the symptoms of colon cancer? A persistent change in bowel habits. Not one time, okay, you went to the fair and you ate a bad hot dog or something, you got diarrhea. It doesn't mean you have colon cancer. But if it's something persistent, it is happening over and over again with some regularity, whether that's diarrhea or constipation. A persistent change in bowel habits could signal something a little bit more serious. Most of the time it's not going to be, but still it is something that probably deserves evaluation. A change in stool caliber or consistency. If your stools become thin or more ribbon-like, that is something that's very important, because again, a tumor there could be squeezing down and causing the stools to be thinner. So again, these kinds of changes should prompt you to seek medical attention. Rectal bleeding or blood in stool. Again, a very common scenario. Some people have hemorrhoids and you can have that happen as well. But again, if these things are persisting, one needs to consider, a diagnosis of colon cancer. Abdominal pain or discomfort, cramps, gas, or pain after eating. These are things that we have to, again, if you're seeing this over and over again, this is something that, again, you should potentially seek medical attention. A common complaint that I see often in my clinic is that patients said the first thing that they noticed was that they would have a bowel movement and they felt like they still had more to go. It just wasn't emptying for them. And so again, that tends to be a common complaint among patients, is that they go to the bathroom, but they don't feel like that everything came out. Unexplained weakness or fatigue. Sometimes this is a result of anemia, or cancers themselves can make people, they secrete things that can make people feel tired and weak. But sometimes they also cause anemia, where your red blood cell count is lower. And because of that, you can have more fatigue. And then unexplained weight loss. A very, very common thing is that, a common story that we get is that somebody says, look, I needed to lose some weight. I went on a diet. I was having some changes in my bowels and some abdominal pain. And then my diet was really working well. I lost 20 pounds and I was thinking, I was excited, but then I lost 30 pounds and I lost 40 pounds. And it was more, I'd even stopped dieting, but I was still losing weight. Those kinds of stories, you need to seek medical attention. It may not be colon cancer, but those are the kind of things that you need to get concerned about, that there may be something else going on. So there are multiple screening options. I'm going to focus on the top two because, in my opinion, those are the only two that are really worthwhile. And number one is by far the best way to screen for colon cancer. We'll talk about colonoscopy. As I said, stool DNA is another way that I think is reasonable, but we'll talk about the pluses and minuses of those things. Flexible sigmoidoscopy, if you're not willing to do anything else, maybe virtual colonoscopy. Again, it's better than nothing. Capsular endoscopy, it can find some more rare tumors than the usual colonoscopies, but again, the top two, the colonoscopy and stool DNA, are the best ways to actually screen for colon cancer. So colonoscopy is the gold standard. This is what is the recommended screening for colon cancer. Now, why does colonoscopy actually reduce the risk of developing colon cancer and reduce the risk of death? Is because you can take out the polyps. Just like I talked about 4 slides ago, colon cancer is developed from polyps. And if you can do a colonoscopy, you can actually remove the polyps. And so you can actually prevent those polyps from ever becoming cancers. And so it's really important that we consider that with colonoscopy, because colonoscopy is about the only way you can get these polyps out. So you can detect 90% of polyps in cancer. So it's not a perfect test, but if the prep is good, you do the whole clean out thing with colonoscopy, that 90% of polyps in cancers can be found. It does provide a diagnosis, and as I mentioned, it does provide an option for therapy where you can actually remove the polyps before they have a chance to develop into cancer. Now, what are the downsides? Nobody wants to go through the prep part, especially. You have to drink all that liquid stuff, and then things are running through you, and you're sitting on the toilet all evening, whatever it is. And so a lot of patients don't want to do that. And so the compliance for colonoscopy can be relatively low. Nationwide, it's just above 50%. South Carolina, we'd actually do pretty good. It's about 70% of South Carolinians are willing to go through some kind of colon screening. Not all of them are colonoscopy, but colon screening. Also, it's not a cheap procedure. Insurance should cover it. And Medicare should cover it. But as I said, it's not a cheap procedure, but it is important. There can be some limits to availability. Not every place can do colonoscopy. There's a small risk of perforation with perforating the colon with colonoscopy, but it's very, very low. It's I think nowadays it's less than 1%. But again, this is by far, to me, the best test that we have for colorectal cancer screening. A test that we see all the time now on TV is this Cologuard thing, where, and I don't want to endorse, I don't own any stock in Cologuard or anything like that, but what that test is doing is detecting tumor DNA in the stool. So basically, at home, you put a stool sample in the package that they give you, and you send it off, and then they, return back results and tell you whether they detected any mutations in the stool. DNA, you can find tumor DNA in the stool, and it can be detected with this Cologuard test. The DNA in the stool is very stable, and so they can be detected in micro amounts. And so this is quite a reliable test. Better than I thought it would be. It's a quite reliable test. The problem with this is that you can detect the cancer, but then if they detect something, you're going to have a colonoscopy anyway. Because if it detects something, then you're gonna have a colonoscopy to figure out what it is. You can't remove polyps with the Cologuard test. Sometimes they talk about, in the medical literature, they talk about false positive results, that quite often the results might not be entirely accurate. They don't miss a lot of cancers, but they can overcall cancers, where sometimes it'll detect an alteration that's not associated with cancer. And what's gonna happen? A colonoscopy. So you might as well have done a colonoscopy to begin with. My usual thoughts in this area is that if you've had a colonoscopy and your doctor says you need another screening, but you've had a normal colonoscopy initially as your first time screening, then I feel a little bit better about doing the stool DNA detection, because you've had a normal colonoscopy before, or a colonoscopy that was low risk before. But again, it's better than nothing. If you can't get you in, if you're not willing to go in and have a colonoscopy done, this can be something that's reasonable. A flexible sigmoidoscopy is almost like you can get half the colon, maybe not even quite half a colon, by doing a flexible sigmoidoscopy. In the past, and I don't see this being done a ton anymore, in the past, you didn't have to be put to sleep for the flexible sigmoidoscopy, whereas a colonoscopy, you had to go to sleep for that. But flexible sig, you didn't have to. It can find colon cancers. You can remove some polyps with this way, but again, you're only doing half of the colon, not even, in my opinion, not even half the colon. So you're missing a good third of the of some of the polyps. And there's some evidence, I don't entirely understand why, there's some reduced sensitivity of this testing in women. And so I put the example in here. Would you do a mammogram only on one breast? Why would you do half the colon with a flexible sigmoidoscopy if you can do a colonoscopy and do the whole thing? Again, better than nothing. Some other ones that people who don't want to have a colonoscopy, they can do this thing called a virtual colonoscopy. And again, it's a special CAT scan or CT scan that generates three-dimensional images. So you do have to go through the bowel prep, and they do distend the colon with air. And but then there's no scope involved. You basically lie on the machine and you have a CT scan done. It does have some benefits where you can identify abnormalities. You know, that's again, so it can be helpful with colorectal cancer screening, and it's non-invasive. So again, there's nobody sticking a probe in you. However, again, similar to the similar to the stool testing, it does not allow for polyps to be removed, and it's quite an expensive test. This is not one that I tend to recommend, but again, it's one of the options that's out there, and again, it's better than nothing. This one's kind of a fancy one, and you can see on the panel here where it's essentially swallowing a pill, and the pill's about a little bit, a little bit larger than a dime, but this is a fancy pill that it has a camera, it has LED lights and a battery, and you swallow it and it goes through the entire GI tract and then comes out and gets collected later. Again, similar to some of the other ones, you can't remove polyps, you can only take pictures of them. There are quite often reports where it's gone through, but it missed something. It missed part of the process, or it didn't, for whatever reason, the camera didn't work or something along those lines. And so sometimes results you get are incomplete. And it's quite expensive to do that kind of thing. And again, so I'm not sure how cost effective it is and how many resources we should be extending towards this. The only upside that I see with some of these things is that you can detect small intestine tumors. So sometimes, not small intestine tumors are not common, but if somebody is having rectal bleeding and they do a colonoscopy and they can't find anything, and you do an endoscopy looking up, esophagus and stomach and the beginnings of the small intestine, and you can't find anything, these things sometimes can help. When you do one of these endoscopy pills, sometimes you can find something in the small intestine that could tell us why you're having bleeding. But I would say that those are rare tumors. And again, those are very, very special cases where we might consider doing something like this. Barium enemas, again, we don't use them very much anymore. They used to use them a lot more often, but because the evidence for using this for colon cancer screening is not great. And again, you can miss polyps, even some relatively large polyps, about a centimeter in size, about 50% of the time. And again, similar to some of the other things we've talked about, you can't remove the polyp. If you see a polyp, you're gonna have to go back in there and get it out anyway with a colonoscopy. So again, why not do the colonoscopy from the beginning? The last test I'll talk about is just testing for blood in your stool. If on a rectal exam or on a stool sample, you'll use one of these cards, it's called a guaiac card. They'll check for blood in the stool. And you can, if blood is detected, there can be a variety of reasons why there might be blood in the stool, but you can, sometimes this can be due to a tumor or a polyp that's there. However, results can also be affected by diet or drugs. And again, if you see blood in the stool, they're going to recommend a colonoscopy. So it's not something that you can do and be finished with. It's something that you can do. You see blood in the stool, then you're probably going to have to get a colonoscopy anyway to tell us what's going on. Now, there are newer generations of this test that can give us, they're better for detecting blood that came specifically from the colon or blood that came specifically from a different location. And so the testing in this area is getting better. But again, if anything's detected, you're going to need a colonoscopy. So again, everything seems to lead back to that one particular test. So it is by far and above the recommendation that colonoscopy is where we should be trying to refer patients for. All right. So here are the current screening recommendations from the American College of Gastroenterology. For average risk patients, that means you don't have family history of colon cancer or anything along those lines. There's some recommendations that say we should start screening at 45. Again, those are, under certain conditions, if somebody gets symptoms, those kinds of things. The evidence how much evidence we have supporting that is relatively low. Where the evidence is very, very strong is in the 50 to 75 age range, where those patients should be getting screened. The strength of recommendation, I said, is very strong. The evidence is good that we should be doing screening there. And then things like my mom might ask me is when can I stop having colonoscopies? The recommendation right now is above age 75 that you don't need to have colonoscopies anymore. I don't feel that strongly about the age 75 cutoff, just because there are a lot of different sort of people above age 75. Some people are relatively healthy, some people are not. And so it depends, how people are at that age. There are 75-year-olds who could live another 20 years, and there are other 75-year-olds who won't. And so, but in the 50 to 75 age range, we should be getting screened. Now, with higher risk patients who have a family history of colon cancer, screening should start at age 40 or 10 years younger than the youngest relative. So if you have a relative who got diagnosed with colon cancer at 42, your colonoscopy should start at 32 at least. Or if somebody's diagnosed really early at 30, colonoscopies need to start at 20. So whoever your youngest relative is with colon cancer, you need to start doing the screening 10 years before that. All right. Once you've had a colonoscopy, though, then the fault it varies thereafter. On the far left, if you had a normal colonoscopy and they didn't see any polyps or anything along those lines, you can go 10 years without having the next one. As I mentioned, if your doctor says you need another screening and you had a normal colonoscopy 10 years ago, you could consider doing the stool DNA testing, as I mentioned, because you've already had a colonoscopy. If they see 1 to 2 polyps that are relatively small, you can say, okay, 7 to 10 years, you can repeat. The reason why I'm saying the 7 to 10 years, as I mentioned in one of the earlier slides, it's 10 to 15 years that process takes to go from a small polyp to a cancer. That whole process takes somewhere in the 10 to 15 year range. So that's why you can recommend that people have a colonoscopy. If they have a normal colonoscopy, they can have another colonoscopy in 10 years. If you have more polyps or the polyps are a little bit bigger, then you need to shorten the time between colonoscopies. If somebody over here on the right side, if somebody has had a lot of polyps, then you may want to repeat the colonoscopy sooner, in as little as 1 year. We'll talk a little bit about the risk factors here. The majority of colon cancers are what we call sporadic. So 80% of these cancers are going to be sporadic. That means they just happen to come about. Whereas 1% come from these inflammatory bowel diseases, things like Crohn's disease and ulcerative colitis. Familial is about 15%, where there's some family history of colon cancer, and then there's some hereditary syndromes that are over here on the right that predispose people to develop colon cancers. So again, family history. Somebody has a first-degree relative that means, somebody who's just 1 degree of separation from your relative wise, your increased risk of colon cancer is about twice. If you have more than one first degree relative, it increases your risk of colon cancer by about 4 times. A relative with diagnosis before age 45, again, almost 4 times increasing your risk. If you have Crohn's disease, ulcerative colitis of the colon, ulcerative colitis of the rectum, you can see that you're increasing your risk, about doubling, in some cases almost going up by almost tripling it. You're increasing your risk of colon cancer, depending on whether you have ulcerative colitis or Crohn's disease. There's also some familial syndromes, these hereditary syndromes, and these are relatively rare, but the ones you might see might be patients who have a history of polyps. When they're scoped, they literally have hundreds of polyps in the colon. Or there's this other one, this hereditary non-polyposis coli, where they don't have tons of polyps. They'll have some, but they don't have a ton of polyps, and it's this thing called Lip syndrome. So these are some family reasons where people have an increased risk for colon cancer. These FAP patients, their risk of colon cancer is virtually 100%. They have colectomies. They have a surgery to remove the colon relatively early in life, usually either when they're teenagers or in their early 20s. Back to the sporadic. As I mentioned, sporadic colon cancers make up about 80% of the colon cancers that we see. And there's some of these risk factors that you can modify, and there are other ones that you can't. So like age, that's how old you are. There's not a whole lot you can do about that. You have a history of polyps, not a ton you can do about that. Diabetes, again, that you can develop that. And obesity, there can be some impact with that as well. So there's certain things that you can do to impact these things, such as diet, smoking, alcohol, physical inactivity. So some of these are modifiable, where you can reduce your likelihood of developing a colon cancer. And you can see over here, you can have a moderate change in colon cancer by increasing physical activity. Aspirin and nonsteroidals like Motrin, ibuprofen have been associated with some reduced risk of developing colon cancers. They more have to do with polyp formation than anything else. Not going to say you should go ahead and take a bunch of aspirin all the time, but there has been some studies that have shown that aspirin can reduce the likelihood of developing polyps. And then there's some other things that can reduce the risk as well, including a high vegetable and fruit diet, high fiber diet, a high folate diet, which again, more green leafy vegetables, calcium, and then postmenopausal hormonal therapy has been associated with reducing the risk of colon cancer as well. So there's some of these things that we can impact upon. So not only can you make lifestyle changes, you can also do screening and catch the polyps early before they have a chance of developing a cancer. And so again, that's what I mentioned in one of the earlier slides, that colorectal cancer can be preventable. It's because of these different factors, that there are lifestyle modifications that we can make, plus actually having the colon cancer screening, you can actually get rid of the polyp before it has a chance to form into a cancer. I'm just going to have one slide on treatment, because treatment gets very, very complicated very, very quickly. With early stage colon cancers, stage 1 and stage 2 and stage 3, you're primarily doing surgery. And then after that, depending on the stage, for some patients, we're able to do observation. For some other patients, you might have to do chemotherapy. For the stage 3 cancers, the ones that have spread to the lymph nodes, you're pretty much going to do chemotherapy for those patients, 3 to 6 months, depending on some of the risk factors. Stage 4, that means the cancer is already spread. By the time of diagnosis, you do chemotherapy. Some patients can end up doing surgery. Some patients can end up doing radiation, but it can vary, but gets very complicated very quickly. Rectal cancer, radiation is almost always a part of the treatment for rectal cancers. And again, it can get very complicated, so I'm not going to spend much time on this at all, but it's something important to know that we do treat rectal cancers a little bit different than colon cancers. The chemotherapy tends to be the same. Stage 4 patients, we tend to treat them relatively the same, but radiation is involved in the treatment of rectal cancers. So take-home messages here. And then we open for questions. Colorectal cancer is very common. It's the 3rd most commonly diagnosed cancer of cancers. It's the 3rd leading cause of cancer death in the United States. early detection, as I've been harping on, can save lives in that at early stages, it's 90% curable. And again, if you can find the polyps, you may not even get to the point of having a cancer. There are clear screening recommendations where, at age 45, you need to start thinking about this thing. If you have any first degree relatives who have had colon cancer, even if you've had no relatives at age 50, you need to start thinking about getting a colonoscopy and how am I going to make an appointment with my doctor to get a colonoscopy completed. All right, that's 45 minutes. All right, we have 45 minutes for questions.
Awesome, we do. And we have one question already from our YouTube audience. And that question is, are polyps part of the normal aging process?
That's an excellent question. So I don't think we have a really great idea what causes polyps, but polyps, the frequency of polyps definitely goes up with age. There's something else that we see in our colons as, people get up in age, is sort of diverticulosis. They talk about having diverticuli in the colon. So it is probably part of the aging process, but it doesn't happen for everybody. So I do think not only is it age, there's probably some environmental factors. There are probably some familial factors that have to do with the development of polyps. So yes and no. In that the older you are, the more likely you have to have more likely you are to have polyps. But I think there are probably other factors that contribute to polyp development.
Awesome. I have a question, family. Don't forget, put your questions in the chat. Keep them coming. We have an amazing expert here to help answer some of those questions. Let's see, I have another one and I'll hold mine for a minute. If polyps are found and removed, can they return?
In general, no. There are some polyps that are on a stalk. They're almost like a mushroom that it has a head on, it has a stalk. And usually if you can just snare those off, those generally don't return. There's some that are more flat and sort of hug the ground. It's not the ground, hug the wall of the colon. And those are a little bit harder to remove. And some of those, when they look at them under the microscope, they can say, oh, we got all the polyp, or you didn't get all of the polyp. And so sometimes they'll have to go back in there and they'll look at it once the polyp is out, they'll look at it in the microscope and they go, okay, looks like a part of it was left behind. And sometimes they have to go back in there and look again to see if they can remove the rest of it or something like that. But once a polyp, say on a stalk, is removed, in general, those polyps are not coming back. But if you've had polyps before, you're at risk for having more polyps again, because for whatever reason, you're a polyp person. You're likely to have polyps again, more that you'll develop new polyps more so than the same old polyp coming back again.
So to that point, does that then increase the schedule for when you need to have a colonoscopy?
Yeah, so if I go back, am I allowed to move my slides? If I go back to my slides here, this one's telling me about the follow-up recommendations. So if you're found to, the recommendation again here on the left is if you had a normal colonoscopy, you can go 10 years before the next one. The more polyps that they're seeing, then the likelihood of going back for more, you have to go back more frequently. The more polyps that they're finding, the more polyps and the bigger polyps they're finding, you have to go back more frequently. Because
even if they're not.
Even if they took them out, because you're one of those people that for whatever reason seem to form polyps. And as I mentioned, we don't entirely know all the reasons why this happens. Could be genetic, could be diet, could be a variety of things. If you're one of those people who forms polyps frequently, your time between colonoscopies is probably going to be shorter.
Awesome. Okay, we have another question. Are polyps considered precancerous?
That's a tough one in that I'm going to say yes, just because if you leave them there long enough, some of them will become cancers. They're not all that way though, because there's some, and again, this is going to get very sort of detailed things, and your doctor can tell you more about this, especially your gastroenterologist, is that there are some polyps that are called hematomatous polyps, which are just inflammatory, and they don't turn into cancers. But adenomatous polyps in general, if you leave them there long enough and they get big enough, they're at risk for turning into cancer. It's not 100%, but they are at risk for turning into cancer. So I'm going to say yes, kind of. It's a qualified yes as far as are polyps considered pre-malignant. It's a qualified yes. Not all polyps will turn into cancers, but the majority of polyps that we see are adenomatous, and those, if you leave them long enough, can turn into cancer.
There's a question here about the age of starting colonoscopy related to sex. Does that matter at all if you're female or male when you start a colonoscopy?
The risk of colon cancer is higher in men by a small amount. And so I've not seen any specific recommendations based on sex that men need to start earlier than women. I've not seen that. But the incidence of colon cancer is higher in men. And so, maybe men should be a little bit more hardcore about it. I don't know, but I've not seen recommendations based on sex.
Speaking of men, you talked a little bit about colonoscopies and not everyone wanting to have a colonoscopy done and some of those other options, although they lead back to a colonoscopy. Mm-hmm. Can you speak to the fears that we, especially as a Black community, and probably more so for men, have when it comes to having a colonoscopy done?
I think people don't like to go to doctors in general. For a variety of reasons. They don't want to hear any bad news. There is, especially in the African American community, there's some mistrust of the medical establishment in general. There's concern about whether this is, is this going to hurt or disfigure me in some way. So there's concerns about that. And again, talking about stool, I had that picture of the toilet thing. I said a lot of people are not comfortable talking about bathroom things, and men more so than women are subject to that, where they don't like to talk about bathroom things. I can tell you what my colonoscopy was like. I can tell you that. In that I don't want to do it, but I said the worst part was the prep. Is that drinking that stuff the night before and getting cleaned out, and then the next day, you go in for your colonoscopy, and actually I don't remember any of it. I remember talking to the nurse saying, "Hey, I didn't, after they put in the IV or the medicine they're injecting you to make you asleep." I said, "Oh, I didn't realize the medicine was white." The next thing I knew, that they're waking me up and saying, "Okay, everything looked good," And so there's no discomfort. There's no recollection of anything. I mean, it's literally like you're talking to them 1 second, and the next thing you know, they're saying, "Okay, Mr. Jones, time to wake up. Everything looked good on your colonoscopy." It's such a the procedure is so quickly over with, and you have no recollection of it or anything along those lines. I didn't understand. After I did it, I was like, why was this such a big deal? I was, again, I surprised myself. I was even saying, why was it such a big deal? Why was I thinking about this so hard? It's just commit to doing it. And as I said, it's really not a bad procedure.
And I think that's probably the sentiment of most people who have actually gone through with it. Is like, I can't believe I was so anxious. It wasn't bad at all. I don't remember anything. Actually, that sleep was really good.
Exactly. I mean, it was excellent. I remember the medicine that they I guess it's propofol, I guess. The medicine that they give you is white. And I said, hey, that medicine's white. That's neat. And the next thing I knew, they were saying, Dr. Lockhart, time to wake up. You're and I don't, there was no recollection between, none. They gave me, you got pictures of your colon, and I was like, hey, okay, all right.
So some of those fears and concerns that you mentioned, there's not a whole lot that, it's not quick and easy to fix some of those fears, like trust, mistrust.
Right.
But starting conversations in our families and in our communities and here in church, where we can talk about things like toilet issues, whatever we want to call it, poop, bathroom, stool, whatever we want to call it. If we can just start being a little more comfortable having those conversations, I think we can ease some of those fears, increase, the likelihood of people actually going to have their colonoscopy, decreasing some of the incidents. Because one of the goals that we have here at Mount Moriah with the Cancer Support Ministry is we want to decrease cancer. We want to eliminate cancer, right? We want to do our part. But in particular, we really want to start addressing some of the health disparities that just unnecessarily impact our community, the people we love most. And having these conversations is one of the easiest ways to do that. And that's why we have you here tonight. And that's why we do these events. But we've got to be comfortable and okay talking about this stuff. It is okay. Put your questions in the chat. I know we don't want to, like I said, talk about the bathroom issues, but those are natural things. I mean, God gave us a colon. He gave us, he gave us poop. He gave us all of these things. It's a natural process. And it's okay to have the questions and it's okay to talk about it. We want to save everyone on this call tonight, on this event, and all of your family members. We want you to be able to take this information back. So don't be afraid to ask those hard questions. I have another question.
I didn't put the slide in here, but there is evidence that how important women are in getting men to do colonoscopy. There's data that the men who are most likely to have colonoscopies are in stable relationships. Maybe it doesn't have to be with women, but as I said, are in stable relationships. And so it is important that, again, your partner, your spouse, that you encourage them to do those things. There is data supporting that men who are in stable relationships are more likely to have, are more willing to have colonoscopies. So we play, if you're not, if you've had your colonoscopy, encourage your partner to get a colonoscopy as well.
That's interesting. I did have another question.
Sure.
I lost it though. Do we have any others? No, it's okay. It's okay. Oh, I know what it was. I know someone who several months ago mentioned to me that they were having bloody stools, but it was found to be internal hemorrhoids. Mm-hmm. And they had a history of that, right? So apparently that had happened several years ago. And then when it happened again, they chose not to seek care because they just made the assumption that that's what it was. So is there ever, how should one differentiate between what might just be a history that they have of bloody stools from internal hemorrhoids versus a change in something new that might need attention? So,
a couple of things. Depending on if that person is 45, have they had a colonoscopy? That's because then if they had a colonoscopy, they found internal hemorrhoids and they're bleeding again. They had a colonoscopy that was normal at 45 or 46 or 48 or 50, whatever. And they had a colonoscopy that was normal, and the only thing they found was internal hemorrhoids, and they're bleeding again. The likelihood of them developing a colon cancer in 6 or 9 months after a normal colonoscopy. Remember, I said it's a 10 to 15 year process to go. So if they've had a colonoscopy that's normal, if they have bleeding, they're in the appropriate hit zone for where they've had their colonoscopy and they're fine and they're having bleeding again, but it's only been a year since their colonoscopy. It's very unlikely that they're very, very unlikely to develop a cancer in that period of time. Again, it's a 10 to 15 year process. If you have somebody who's 35 and they have never had a colonoscopy and they have bleeding and the doctor evaluates them and says, it looks like internal hemorrhoids, something along those lines, but it happens again, or, if they have persistent symptoms. And again, like I said before, that's where you should probably ask your doctor, hey, can I get a colonoscopy? Again, it depends on your age. As I said, but as I say, go back to the other thing. If you're 60 years old bleeding, you had a colonoscopy last year, it was fine. I'll be much less worried about somebody like that if they show up again with hemorrhoidal bleeding. I hope
We
that
have
makes
another question. Can there be a better prep procedure than drinking the solution that's available now?
So the prep has changed over time. And different institutions have different standards as far as what the prep is. I remember it used to be that you had to drink this whole gallon thing, this thing Go Lightly. And then I think when I did it, I had to go through a whole box of Miralax or something like that. So everything is different. Nowadays, I don't even know. I think now it's like Miralax and some Dulcolax or something. Every institution is a little bit different. But the point is with the prep is that you have to get as clean out as possible. Again, we're going to talk about bathroom stuff here. You have to get as clean as possible so that they can, when they do the scope, they can see what they need to see. If they go in there and things are, if it's not clear because there's still stool in there, you haven't been cleaned out, then you're not going to have a good quality colonoscopy where the doctor at the end of it can say, look, you are good. We didn't see any polyps, didn't see any tumors, didn't see anything. If you're cleaned out, then your doctor can give you a better sort of clean bill of health. And so while the prep is the most annoying part and the part is sort of the biggest downside to all of it, it is important that that everything is cleaned out so that they can get good pictures and a good look at the colon when they're in.
Okay, thank you. I think we have time for another question or two.
Tiffany?
I believe everyone is unmuted right now, so we will allow you to ask a question if you have one, or you can continue to put your questions in the chat for just another minute or two. Deacon Cakeley, you have a question?
Yes, Tiffany, thank you. I had my last colonoscopy at age 72, and I was informed at that time that I would never need another one. The result was that they found a small benign polyp, but they still informed me that I would never need another colonoscopy at age 72. Is that correct?
That's about right. As I said, I have the guidelines in front of us here that they're generally recommending that people, don't need colonoscopies above 75. So if you had a close to normal one at 72, your next one would be, 10 years from now. So, again, next one would be 10 years from now. So, 82, and you'd be back above 75. You probably don't need another one.
Thank you.
We have another question from YouTube. What percentage of tumors found in the colon are cancerous?
Tumors. If you find a tumor in the colon, it is, I don't know what the percentage is, but it's very, very high. In general, the colon you don't form a lot of tumors in the colon that are necessarily benign. It's a low percentage. I don't know what the percentage is off the top of my head, but it's a relatively low percentage of tumors that are found in the colon that tend to be benign. There are some things some inflammatory things that can happen and those sorts of things. But retained foreign bodies can lead to inflammatory response, but those things are rare. If the assumption is that it is probably malignant. It's malignant until proven otherwise.
All right, we have a question, Deacon Shepherd, hand raised. Yep, I see you.
Yes, ma'am. Good afternoon, everybody, once again. Dr. Lockhart, I was just sitting there pondering about as far as the diet that we do, with a lot of antioxidant food like blueberries, broccoli, and all these other different type of antioxidant that we could take. Would that help a whole lot from polyp actually developing?
think so. It's not, again, it's not a proven entity. I can't say that for sure. We do know that eating that kind of diet does reduce your risk of developing a colon cancer. Now, we know that the majority of colon cancer develop from polyps. So if you're reducing your risk of colon cancer, you're probably reducing your risk of developing polyps by having a high fiber diet and a high antioxidant diet and those kind of things. So you probably are. I have not seen studies specifically linking those two. You know, we know that taking anti-inflammatories does reduce polyp development, and diets like that reduce our sort of the inflammatory components in your system, and so it is probably conducive to developing fewer polyps.
Thank you, sir.
All right, do we have any other questions? That was most informative. I think one of the things that many things I didn't know, but one of the things that stood out for me was that if you have a relative who was diagnosed, that your screening should start 10 years younger than that. That really stood out for me. But thank you. That was awesome, awesome, awesome information. Any other questions? Okay. So I think yes.
Okay. Good evening. One question I forgot to ask. Why don't the doctors use the citrus magnesium anymore and they use Miralax and Docalux?
I don't know. I think it's sort of a gentle thing. More than I think people consider, magnesium citrate to be relatively sort of, to use a different word, but a relatively rough kind of laxative. Where I think Miralax is considered a little bit more gentle. I don't think it has anything to do. I'm not aware that it has anything to do with sort of preferences over time. I think I think Miralax is a little bit easier to regulate, in that you can say, every day, 3 times a day, or I shouldn't say that, 3 times a week or 4 times a week, that kind of thing. Whereas magnesium citrate, you drink a half a bottle and it's going to come through you. Whereas I think something like Miralax, it tends to be a little bit more gentle. I think it has to do with how rough a particular laxative is with you.
So if someone, if someone being constipated a lot and they take that citrus magnesium, would that kind of like mess up the walls of their intestines?
Not if you're using it over and over and over and over. If you're using it too regularly, yes, you could have some issues with not necessarily the walls per se, but sort of throwing off the normal bacteria that are there. And people talk about sort of these yogurts that have bioactive ingredients and those kind of things. You can throw off your equilibrium in the colon if you're doing those sort of heavy things too often.
Yeah,
I think Miralax, again, I'm not endorsing one brand or anything. I think Miralax, the thought is that taking Miralax one time is not necessarily going to have just say, if I'm constipated, I'm taking Miralax. Some people it works that way, where it sort of works for them that way. But a lot of people, the Miralax, if they're constipation that they deal with a lot, something like you take it, once you take it Monday, Wednesday, Friday, or something along those lines, just to keep things at a kind of a regular pace, as opposed to using it for, I'm constipated, I need a one-time fix. That's more, the one-time fixes are more in the milk of magnesia, magnesium citrate, those kind of things that are a little bit rougher and kind of, push everything through. Whereas I think something like Miralax is considered more a little gentler and something that you might use for sort of chronic low-level constipation.
So would the individual use it, even if they use the Miralax, that they should more or less have a colonoscopy as well? Because it seems like you shouldn't have to be using that and to have a bowel movement.
are you in, again, it goes back to the question somebody asked, if you're in the right age range, and if you're in the 50 to 75 and you've had a colonoscopy, and your colonoscopy was 2 years ago and you're having constipation again, I'd be less worried then. But if you've never had if you're 55 and you've never had a colonoscopy and you're having trouble with constipation, you need to go get your scope. I think it all depends on, for me, a lot of these things are how risky some of these things are. All depends on when did you have your colonoscopy. If you didn't have one, then yes, I'm more worried about you than other people. If you've had one, it's only a year or two ago, and it was clean, I'm not nearly as worried about your constipation that is bothering you.
Okay. Yeah, I seen that happen to some people I know, that they take that stuff a lot, and that make me think something else going on with them as far as within their colon.
There could be. I mean, a lot of constipation, honestly, is hydration. A lot of us don't drink enough water and drink enough fluids during the daytime, and a lot of constipation is hydration. If people would do better with drinking, about 2 liters of fluid on a daily basis, again, that sounds like a lot, but if you would work on drinking about 2 liters of fluid a day, a lot of people would be less constipated.
Amen.
Thank you.
Thank you, sir.
Okay.
Okay, we have one other question in the chat, and then we have a hand raised, Deacon and Deaconess Williams. Your hand is raised. Do you have a question? Okay, I'll go with the question in the chat, and it is related to the question that I asked about, or comment I made about having a colonoscopy 10 years younger than a relative being diagnosed. And this person wants to know, what is the youngest age you've seen in that situation?
I have had patients with colon cancer diagnosed at age 19. That's the youngest I can remember. I mean, in some of the, and I have it on a different slide here. If we look at this one, the green one on the top here, from familial adenomatous polyposis, those people are diagnosed with colon cancers in their teenage years. So again, but that's a strong family history. But in general, I would say that person, the youngest person I've ever seen that did not have any kind of familial thing, was about 19 years old, and that's very, very unusual.
Wow.
As mentioned, 90% of patients are diagnosed above age 50.
Okay. Well, thank you so much.
Hello, I have one question.
Yes, ma'am.
Okay, thank you so much, Dr. Lockhart. The information is so very educational, and I'm sure we take it at heart to take care of our bodies and prevent getting this disease. Well, my question is, does Tylenol reduces polyps? Because I cannot take aspirin.
No, Tylenol does not. It works in a different way, and it does not. Now, the reduction in polyps is very minor with aspirin or ibuprofen, those kind of things. I wouldn't worry about it. There are other ways, as I said, to eat it. There are other ways to reduce your risk of polyps by healthy diet and high fiber and those kind of things. There are lots of people who are allergic to aspirin and allergic to ibuprofen and those kinds of things. And there is some reduction there, but as I said, it's not worth, the reduction is not worth putting your life at risk for taking a medicine that you're allergic to.
Okay, thank you. Appreciate it.
All right, that's the last question. We will begin to wrap up. So thank you all for joining us tonight. I pray that we are leaving you, Dr. Lockhart is leaving you with knowledge and empowerment that you're going to be able to advocate for your own health and someone you love. We know that knowledge is power, and I pray that we use this information to do better. Let's live our best life by just being empowered and full of knowledge. And I also wanted to take a minute to thank the Cancer Support Ministry for yet again another wonderful cancer educational event. But specifically, I wanted to thank those who work so quiet behind the scenes to put these events on and to do the hard work to make it all come together. The faith planners, that's Deaconess Gaffney, Aletha Fields, as well as Hattie Baylock. Thank y'all. Thank you, ladies, so much for all that you do behind the scenes and for everyone in this great ministry. And most important, I wanted to thank Dr. Lockhart for taking the time out of his important and busy evening to spend with us tonight. You are welcome to come back anytime if you ever need to call on us to do anything for you as a cancer support group. Please do not hesitate. We are here and we're willing to help support you in any way, advance your cause of trying to help a community do better. So if we can ever, assist you in that, don't hesitate to let us know. And as I said, you can come back anytime you want. And we'd also like to invite you. You can visit us on Sunday for worship service, 11 o'clock. That's live or on YouTube. So you now have a new family. We're here for you as well. So again, we thank you. And I will turn it over to Deacon Shepherd to close us in prayer.
Thank you.
To God be all the glory for the great things he have done and is still doing even in each and every one of our lives. And I also like to thank you, Deaconess Tiffany, for your part in playing in this event as well too, because we don't want to leave, no one not noticed. But we give God thanks for you as well. So let's go to the throne of grace. Eternal and everlasting Fathers, once again, we come now thanking you for what has been done, and even for the wealth of information, oh Lord, that we can get rid of a lot of the stigma that we have heard, and other people say that's not part of the medical field. And we thank you for the doctor that came out and give us some real good information. And as I'm reminded what the scripture says in 3 John 2, that we pray that we would prosper and that we would be in health, even as our soul prosper. Now unto him who is able to keep us from falling and present us faultless in the presence of his glory, with exceeding joy, to the only wise God, the glory and majesty, dominion and power, both now and forever. Amen.
Amen.
Y'all have a great day.
Amen. Amen.
Good night.
Good night.
Thank you, Dr.
Thanks
Lockhart.
again.
Thank you.
Very much.
Thank you so
Thank
much for having me.
you.
And I appreciate the blessing. Thank you.
Yes, sir. You are blessed.
Dr. Lockhart, I will be in touch with you after this, and I appreciate it again for you taking the time out of your schedule.
Absolutely. I'm happy to talk anytime.
Okay, great. Thank you. Have a good night, everyone.
Good night.
Good night.
Everyone.
Good night. God bless.